medical school in 1981, the basic program was, we're going to stuff your brain full of medicine, and we're going to teach you how to care for patients one at a time. It's like, okay, that sounds like fun. I'm interested. I think I can do this. And I did that. If I put this up here and it falls down, that would be most unfortunate. I'll just hold on to it. The phrase care management didn't exist. And in fact, the concept of teams caring for patients did not exist. So let me just talk to you about what care management is. Because a lot of times we start conferences, we talk about stuff, we don't even know that we're using the same language for the same thing. So what is care management? Care management is a process whereby usually nurses, either located in primary care offices or located centrally in their ACO, reach out telephonically to patients with, oh, thanks, Larry. Place for my water. He's a good man. To help patients with complicated medical problems, complicated socioeconomic problems, complicated behavioral health problems, and bring a team approach to helping these patients get the care they need. So that is what care management is about. We've heard about it for a number of years. There are different ways to go about it, and this morning I'm going to focus on what I call predictive analytics to choose the actionable patients, and this is important. So you know who I am, we can skip this part. Just a moment about Arcadia, the company I work for. I am the Chief Medical Officer. Arcadia is located up the road in Burlington. We're a 15-year-old company. What we do is aggregate disparate data, medical data, claims data, EHR data, lab, medications, anything we can get our hands on. We aggregate all that data. We clean it up. We curate it. We make it usable. I made that sound really easy. It's actually not really easy. And we have a series of analytics that sit on top of that allow ACOs to get the job done and be financially successful in their contracts. We have over 50 million patient lives that we've dealt with up at this point. And I will say we're very proud of being #1 in class, that's KLAS, this past year. So these are the items I'd like to cover with you this morning. Why do we need better patient stratification? How do predictive analytics work? How do health systems use predictive analytics for stratification? How does this support care management, and where do we go from here? I think we can do that in about 30 minutes. I'm going to start with a patient. This is, since I'm a real doctor, this is a real patient. And I was thinking to prepare for this talk, who should I talk about? And I remembered this patient. I was very fond of this patient. And I want to present this patient to you because this is the kind of patient that in the old days, it was just me and Manny. And I didn't do a very good job taking care of Manny because Manny had a lot of problems that I was not well trained to handle. So at the time, he was 62. This is all true, by the way. None of this is made up. This is all true. He's a single parent of a teenage son. He was unemployed. He was on disability. He had worked as a chemist and then a journalist. Then he began having seizures that made him unable to work. He had personality changes. He had run-ins with the law. Due to some violent outbursts, he ended up in jail. Doesn't smoke or drink, doesn't use drugs. Stable, but he has some problems. He has morbid obesity. He has a seizure disorder. He has chronic swelling of his legs, cellulitis, infections, asthma, diabetes, chronic kidney disease. This next part's very important. He's on multiple medications, including a high dose of Valium. I'm just curious, how many people in the audience are healthcare providers? Okay, so we have a few. And you all know that a high dose of Valium is kind of a red flag. Why is a patient on a high dose of Valium? It actually worked for this patient's seizure disorder, but there's a lot of stigma about high doses of Valium. So whenever this patient went to another hospital that wasn't connected to Beth Israel Deaconess, and they didn't have access to his medical records to understand that he needed the Valium, what did they do? They'd stop it. And guess what happened? He started having intractable seizures, then he'd end up in the ICU, and then they'd call me and we'd get him transferred back over. Not good care. He has an excellent relationship with his son. who's a junior in high school and plays on the baseball team. So I think you get the picture that I, as an individual internist caring for a patient like Manny, was I any good dealing with his transportation problems? No. Was I any good dealing with his financial problems? No. Was I any good dealing with his behavioral issues with his son? No. That was the old days. Then we developed a care team, the new way. I had a nurse practitioner, I had a social worker, sometimes we had a psychiatrist who was even on our team, and the care was better for Manny. He liked it better, I liked it better, and the point I want to make for the financial people in the room is not only was his care better, it was less expensive because he didn't end up in the ER, he didn't end up in the hospital unnecessarily. I'm not going to read this definition, you can all read it. I'm just going to point out a couple of important parts. That care management, what I'm talking about today, is a subset of what we call population health, which from the Arcadia perspective is about aggregating all these sources of data and using it for improving the health of the population and improving financial performance. And then you'll see in green there at the bottom it says, and to power care management. Okay, so care management challenges. Who are the right patients? What's the right panel size? And what kind of programs am I talking about? If we over-select patients for care management, what's wrong with that? That's great, more patients get care management, sounds good. Not good. Why? Because if you're the financial person in the room and I tell you we have 10 care managers, you say, okay, well that's $1 million a year. How do you know we're using that $1 million wisely? So we don't want to over-select patients who don't need care management. We don't want to under-select. If we under-select, we're leaving patients off who would be benefiting from the services. So how do we do that? So predictive analytics that I'm going to show you today, some of our secrets from Arcadia, is how we choose the right patients. Panel size. This is not something that Arcadia would tell a customer what to do. This is really a business decision. It's a strategy decision. How many patients do you want your nurses to handle? I'll give you a tip. It might be as few as 50. It might be as many as 200. It really just depends on how intense do you want those interventions to be. And then finally, is care management going to interact with a disease management program? So again, here we go defining terms. Disease management is not the same as care management. Disease management is taking an illness, and I'm going to name the big six. These are the big six, especially in the Medicare population, that if you have the resources and you have the will, you should do this. Diabetes, congestive heart failure, COPD, chronic kidney disease, behavioral health, and last but not least, I guess it is last, end-of-life care. That is always last. Most organizations don't have the resources to have all six of these, but hopefully you're thinking about moving in that direction. And care management needs to dovetail with disease management. Now, I always get this question, so I'm going to ask it rhetorically right now, and I'm going to answer it. Dr. Parker, how do you determine the financial return on investment of care management? Is it a fair question? You agree? It's a fair question. It's a good question. It's a hard question. In fact, I ran into a physician. He's not here today, so I can tell the story. I don't see him. I ran into him at my gym a few weeks ago, a prominent physician in Boston. And he came up to me and we were chatting. He said, I don't believe in care management. He said, I don't think it works. And I did a little double take, and I wanted to get about my exercise. I didn't want to get into an argument. But I disagree with him. I think it does work, but you have to know what you're doing, and you have to do it correctly. And proving the ROI is not simple. So here are the 3 ways you can prove it. Number 1 is what I call the faith-based method. Quote from me, we know it works, and we don't have to expend resources proving it. Now, if you ask my opinion, I'm going to vote for that. On the other hand, if you need to prove it, there are 2 ways to do it. Number 1 would be a retrospective review. So you'd look at all your patients in care management. You'd look at time X where they started. You'd then look backward a year to see what their utilization was. You then look forward a year after they started care management, and hopefully you would see a decrease in utilization and a decrease in cost. The third method is some kind of modified case control method. What do you do there? And I'm going to show you this in a minute, because this is what we do at Arcadia, modified case control. You take a cohort of patients under care management, let's say 1,000. Then take 2,000 patients that are similar comorbidities. You run them forward. You've got the care managed patients, the control patients, and again, you look at overall utilization. So here's the pyramid that you all have seen many times. Hopefully all of us in the room are at the bottom of the pyramid. We're low cost, low risk patients. And by the way, I call patients patients. I don't call them beneficiaries. I don't call them covered lives. I just think that's kind of insulting to people. I mean, people are patients. And then we have in the middle this rising cost, rising risks. Those are the people that are going to begin to incur multiple comorbidities, a lot of utilization, a lot of expense. And then at the top of the pyramid, we have the high cost, high risk. Now, you might think that care management, just take the top of the pyramid off and manage those folks. Wrong. Wrong. And you'll see there that risk does not equal impactability. I'll give you a couple of examples of why that is true in a moment. But what this graphic shows is we want to give the care managers the right patients. We want to give them the impactable patients, the patients for whom they can make a difference, improve their care, decrease their utilization, decrease their cost. Okay, so I think I just said it, but I'm going to reiterate it. The two goals of care management are to improve the health of the population that they're caring for and decrease cost. And let me be very specific about the utilization, because you might say, well, that sounds kind of fuzzy. Decrease utilization, what are you talking about? I'm specifically talking about decreasing ER visits, decreasing hospitalizations, and decreasing TCOC. Raise your hand if you know that acronym, TCOC, okay, total cost of care. And if we can't do that, we're not doing a good job. You can mess up care management. That's the thing about care management. You can mess it up and not improve care and not decrease cost. But if done correctly, you will improve care of the right patients and decrease cost, and everyone's going to be happy. So I mentioned to you that it's a little counterintuitive that the top of the pyramid are not necessarily the people you care manage. Why not? Let me give you a couple of examples. So a patient with end-stage metastatic cancer, that patient has been on a long, painful, high-utilizing, expensive journey. And care managing that patient isn't going to change the trajectory of that patient, the outcome for that patient, or the utilization for that patient. Not a good patient to care manage. They need other services. They might need your behavioral health program. They might ultimately need your palliative care program. They don't need care management. Let's take another example. Car accident. 25-year-old car accident, 2 broken legs, broken arm, multiple fractures, goes to the ER, goes to the OR, has a lot of surgeries, big bills, probably costs $80,000, $100,000. Rehab, patient's all better. Not a good candidate for care management. Very expensive, not a care management patient. Now, traditional risk algorithms really have been designed for risk adjustment, not for population stratification. What do I mean by that? You all know that in your contracts, it's based on some kind of benchmark, and that benchmark is the aggregate risk of the population. And that aggregate risk is the concatenation, I think that's the right word, the pulling together of all the comorbidities. It works fine to establish the benchmark, but that's not what this is. We're trying to choose the right patients for care management. Also, traditional risk algorithms don't have all the data that are needed to predict who will benefit from care management. So here's where we get into the fun part about what is predictive analytics. So it's not about finding out what's happening right now. Who are my patients in the ER in the hospital right now? Yeah, I need to know that, but that's not predictive. That's just saying what is right now. It's not about predicting exact outcomes in the future because no one can do that. But it is about taking all the information available to us at Arcadia, claims, EHR data, I'm going to show you socioeconomic data, all of this data, and from that we will infer potential trends and outcomes so we can predict what will happen with certain groups of patients. And that is very powerful. So what capabilities do we need? Well, I just said we don't need necessarily the sickest or the highest cost patients, but we can start looking at different populations. So we might look at the Medicaid population. We might look at commercial. We might look at Medicare. We might look at diabetics. We might look at patients with heart failure. So this care management strategy is really a flexible tool that has to fit the business needs of your organization and the care goals of your organization. I'm just going to see how we're doing on time. I'm doing pretty well. Okay, this is my favorite slide. And this pointer works. This is fabulous. Okay, great. So we're going to spend a few minutes on this slide. So please bear with me. Can everyone in the back sort of see it? Sort of, maybe? Okay. We have three groups of patients. We have a control group. We have care-managed patients. And then these are the impactables. It sounds like an old TV show, doesn't it? The impactables. These are the patients that Arcadia has designated as highly impactable. So we took 2,500 patients here, 2,500 patients here, 1,000 patients here. Time goes this way, time goes down. So they all went for a year. Control group goes for a year. And then we start measuring. Control group keeps doing what it's doing. The managed patients with normal care management, you can see all these squiggly lines. They seem to be shifting to the left. That's a good thing. And then these are the most impactable patients, and these squiggly lines, which each represent one of these metrics, are moving even more to the left. So let me be very specific about what's going on here. We'll jump down here. So, for example, bottom line, per member per month. The control group, their PMPM went up 17%. Okay, that could happen in a year, not surprising. The managed group, look at them. They went down 18%. That's good. So these nurse care managers are making a difference for this cohort of patients. But look at this. The ones that we said were most impactable, their PMPM went down 26%. Now you could say, okay, maybe you were lucky that year. Maybe, maybe not. But if you start looking at every metric, so leakage, that means patients going out of network. So 20% went out of network in the control group, but for the managed group, down 17, down 21. This is interesting, hospitalizations. There's a lot of random activity around who gets hospitalized in a year, but it's not all random. But here, this went down 23. This went down 25. This went down 36. And you can see for every one of these things, the highly impactable patients chosen by our algorithm had the best outcomes. The exception is medications. And if you think about it, this is actually reflecting a number of medications. A highly correctly managed patient might need to be on more correct medication. So that's not necessarily a bad thing. So I think that this shows that when you apply care management, so to my friend the doctor at the gym who said care management doesn't work, I really would like to show him this slide. Because look, it all shifted to the left. And look here, it shifted even more to the left. We'll have time at the end for questions, but this is really the most important slide I'm going to show you today. I'm just going to run through in a few minutes how we built this model. I am far from the tech guy on the team, so my understanding of tech is low, but hopefully these slides will make a little bit of sense. So the way we built the model was we started with an unmanaged population, and then, as I talked about, that was A, and then B are enrolled and managed patients. At the bottom, we have an individual patient. And then we have inputs. What are the inputs into the model? Demographics, morbidity, those are their illnesses, utilization, census factors, which I'm going to show you more about in a minute, care coordination. Care coordination is interesting. Care coordination has to do with the ratio of specialists to primary care doctors. And guess what? The more primary care visits a patient has, the better. So we actually look for any individual patient or group of patients, what's the ratio of specialists to primary care? And then we have the outputs that I talked about, the cost utilization. Here are some of the inputs. I'm not going to go through every one of these, that would be a little crazy, but you can see some interesting ones. For example, we have something called care team density under care strata. That's up here. That has to do with where are a patient's doctors located? Are they all in one system where they communicate with each other through one EHR? That's great. On the other hand, if the patient has doctors at BIDMC and doctors at Dana-Farber, they're right across the street, and guess what? I worked there for 30 years. They don't interoperate. How crazy is that? So the more discontinuous, the worse. So we look at all of these factors. See if there's anything else on here I want to mention. We look at, obviously, quality gaps in care, activation and adherence. Are they taking their medications? How do we know? We know from claims data whether they're filling their prescriptions. Now, this is some really interesting stuff. This is census data. We get information from the patient, obviously, him or herself, but there are things that the patient may not tell us or the patient might not even know, but we get this information. So SDOH is another acronym that's come into use recently, Social Determinants of Health. And what is that all about? Well, where do they live? What is their income? What is their level of education? What is their housing situation? What is their transportation situation? It's not on this one. Have they been incarcerated? Are they incarcerated? Are they below the federal poverty income level? Percent of households with children and a single parent, goes on and on. This data is available to us through the Center for Disease Control. And you can see this just happens to be Cambridge, our fair city. And it gets down to just a couple of streets. So this is really granular information about, it's a little creepy in a way. I mean, it's almost Big Brotherish how much we know about you. So if we know where you live, we know a lot of things, we can infer a lot of things about you. We build that into our model, and that helps us predict the impactability of care management. This is just to show you that I'm just trying to impress you with kind of some math sort of stuff. Some of the factors don't affect care management impactability, and some do, and that's just what this is showing you. I'm not going to go through all these things, but for example, this is drug abuse. There's a high correlation. So that makes sense, right? If somebody has a problem with drug abuse, they're going to have problems in their life, and they're going to have a lot of utilization, and care management probably a very good idea for them. Educational attainment, also highly correlated. And then we find there are some things that are not highly correlated, sometimes counterintuitive. So back to building the model. We have the unmanaged population, then we have the managed population, we have the inputs, the outputs, and at the bottom we have the individual patient. And we're going to see what happens. But also, before we get to the end of that graphic, I want to show you a little bit more of what's under the hood. So this is really getting into some deep math. I'm just curious, how many people here have taken differential calculus? Raise your hand. Hi, differential calculus. Okay. How many people have taken integral calculus? Okay. And of those of you with your hands up, how many finished integral calculus? Okay, I didn't finish integral calculus. I've met my match in integral calculus. This is very complicated math. So basically what's going on here is our data scientists at Arcadia are taking all of these factors and they're figuring out, based on, from the key, the impact on total cost of care, unplanned inpatient admission, avoidable emergency department. For all of these different factors, how are they affecting the model? So just to give you a hint that if you want to go home based on this talk today and build this yourself, it's going to be very difficult, really difficult. So back to our model. As you can see, we have all the inputs, we have the outputs, we have the difference in the populations, and then we have the projected impact of care management. And then for an individual patient, we end up with actually an impact score for every individual patient that we cover. And that's how our system works. I think we are coming down the home stretch. Yes, I just have a few more slides, and then I can take some questions from you. If you take this is not a random sample. This is a sample of about 140,000 patients that we used for one of our cohorts. This just happens to be an example. And you can see that in a population, as you would expect, the majority of patients are to the left of this line, meaning they're low risk, they're healthy, they're not going to benefit from care management. We don't need to worry about them. But then as our impact score rises, we see that more and more patients start to fall into these higher risk categories. So this is the highest potential, 1,577 out of about 140,000 patients. So this, if you're an ACO or a large healthcare organization, you might want to run something like this over your population to understand the stratification of risk throughout your population. And then not only do you know it, but now what are you going to do about it? And the what to do about it is how to organize your care management. So my last comments are going to be just some tips about how to use a care management tool like I'm showing you today. And there are 4 ways to do it. The first is called rank segmentation. Really, all we're doing there is we are taking your population, we're applying our algorithmic methodology, and we're ranking them from most impactable all the way down. And we're saying to your care managers, here you go, ladies and gents, go care manage them. It is a strategy, may not be the best strategy. It really depends upon the goals of your organization, your business needs, your care management strategy. There's always a head of care management. There should be a head of care management, and that person needs to interact with the medical director and the CFO, and it's really got to be a team effort to figure out which care management strategy are you going to use and what's going to be most helpful to your organization. The second one is called score clustering. This strategy, you might say, you know, we did great in our Medicare contract, we did okay in our Medicaid contract, and we did really poorly in our commercial contract, and we did some analysis, and we found out that a lot of patients in the commercial contract were ending up in the ER unnecessarily and getting admitted unnecessarily. So let's focus our care management on that population. So that's just an example of score clustering, how you might flexibly use this tool. Population-driven segmentation. So this could be, for example, we noticed that in Medicare, we have a lot of patients who end up in the ER, get admitted, go home, and they're just cycling through, and we're not controlling unplanned, unnecessary admissions. Patients with heart failure, patients with asthma, patients with cellulitis. So we're going to take those patients, and then we're going to run the algorithm, and we're going to care manage those patients. So that would be a population-driven segmentation strategy. And then finally, an initiative-driven segmentation. So your leadership might say, or your medical leadership might say, you know, we've got a problem with heart failure and diabetes. We're not doing that well. Our quality measures aren't that good. So let's focus this year on heart failure and diabetes, and let's run the Arcadia algorithm against that population and care manage those people. So finally, this sounds great. It does work. There was a TV commercial a long time ago. It said, "It really works." Does anyone remember that ad? It really works. It really works if it's used correctly. Having said that, like any tool, it's not perfect. There are caveats. So this graphic, not only is it pretty, but it makes the point that there are some counterintuitive things that can happen with data. So for example, in the corner, you saw the low-cost, high-risk patients. And sometimes those are the patients that you need to look for, and sometimes our system is going to bring that up. So let me conclude where I started, which is with my patient Manny. And when I first met Manny, he was a younger man and I was a younger man, and I did my best to care for him. And I really didn't do that great a job. And then when we got the care team organized, we did a much better job of caring for Manny. He was a happier patient. The CFO was happier because he utilized less and cost less. And hopefully I've showed you this morning that this exciting technology, algorithmically driven, can help organizations find the right patients for care management. Thank you very much. I think we have time for some questions, and I know there are some microphones available, so feel free.
Thank you. I'm Janice McCallum. I just want to go back to the beginning of your talk. You mentioned, you aggregate a lot of data from as many sources as you can get, and then you can go on to the more sexy things like the analytics and that type of thing. But can you talk a little bit about what the issues are at that early stage of actually getting the data in a useful format? I mean, it could be access, it could be people who know how to normalize it or whatever, but I don't want to give you the answer there. But
sure.
Thanks.
So the process of data aggregation, actually a lot of it is not, the challenge is not to us, but it's actually to our customer. So our customers, first of all, have to get us access to all the data feeds. So typically, a typical customer like an ACO would have commercial insurance. So we need those monthly data feeds. We need the monthly Medicare feeds. We need the monthly Medicaid feeds. And then a typical ACO might have 5 different electronic health records that they're using. They're using Athena, Cerner, GE, you name it. We need to get all of those feeds. And we have the technology to get we call them pipes or connectors, and we connect to all those EHRs. That data we get nightly, and we download it nightly, and then each customer, each ACO has its own place in the Amazon cloud. We use Amazon cloud. We think that's the securest place for data. And every night it's uploaded, and then I can't explain how it gets curated and cleaned up, which it does. That's the technical part. But and then we also have that data asset available to the customers, so if they want to do their own analytics, they can get in there and do whatever special products they want. Does that help answer your question? Great, okay, thank you. Other question, yes, sir.
Hi, Brad Deepice from Persistent Systems. One question, have you looked at...
Where are you located? I can't see.
Back here.
Okay,
all
great.
The way back
Hi.
Here, yeah.
Okay.
Have you guys looked at the cost of the care management interventions, and specifically the costs relative to the decrease in total cost of care? Presumably, obviously, you're delivering better care for patients, but then from a financial ROI perspective, is this actually saving money for the health system?
Yeah, great question. So you may have heard me say, I said it really quickly early on in the talk, 10 care managers, $1 million, right? It's probably not an unreasonable cost all in, depending upon the part of the country that you're in and cost of labor and overhead. Our experience is that when used correctly, net of the cost of hiring care managers and their overhead, you are still coming out with a substantial financial return on investment. So the answer is yes, net of the cost of the care managers. Thank you. Good question.
I'm Joe Heyman from the Mass Medical Society. I didn't notice on your favorite slide anything about outcomes.
Right.
And you know, most of what you've been discussing is saving money. I haven't heard a lot about improving outcomes.
Yeah. I tried to make the point at the beginning that it is about improving care. And that, for example, the highest risk patients who are rotating through the hospital by having nurse practitioners make home visits, that is a tremendous improvement in care for the patient. Filling quality gaps where they haven't gotten vaccinations, they haven't gotten cancer screenings, that is important for care. Making sure patients are taking their medications, that is important for care. My experience working with nurse care managers is they are highly trained and excellent at helping patients take better care of themselves. I think your point about measuring health outcomes is really good, but when I said that we measure ED visits and inpatient visits, that's a pretty good proxy that we're going in the right direction when patients are having fewer ED visits, fewer hospitalizations. We feel that's the right direction. But your emphasis on quality of care, I couldn't agree with more, and as a doctor, I completely agree with you. So if I made this sound like it was all about the money, that was not my intent. It's about improving quality of care and saving costs to the system both. I think we have time for, a couple more questions. Sure. Right here.
First of all, thank you for speaking with us this morning. And Pat Rio, I was curious when you talked about the quality gaps, what processes you have in place to improve that, kind of jumping on Dr. Heyman's comment too.
So the question
And I know
is
it's not all about the money.
Quality gaps specifically? Right, so quality gaps, all of the contracts that you have, whether it's Medicare, Medicaid, or commercial, they all have quality measure requirements. Now, I am the first to say, as a formerly practicing physician for 27 years, those quality gaps are not the totality of the quality of care. We all know that. But having said that, the quality gaps are important. We want women to get mammograms and pap smears. We want children to get MMR vaccine and Tdap and all the vaccines that they should get. We want people to get the quality measures that are available, and so our system shows the gaps, and it can help ACOs or organizations do outreach to patients to get them in. And we've shown very clearly that if you employ a system like ours, and ours is not the only one, there are many that do this, if you put the effort in, you can really improve performance on those, filling those quality gaps, and that's a good thing. Other questions? Yes.
Bob Dichter from Compass Medical. So I'm going to ask this question on behalf of somebody who's actually not here right now. So on pharmacy costs, I see you showed on your slide that you actually increased the cost in some of the pharmacies, or increased the medications, I should say. But pharmacy costs are becoming enormous, and in many organizations, actually, the cost of drugs are actually exceeding the cost of regular side of healthcare in terms of hospitalizations and outpatient. And given that trend and the high expense of cost, where do you guys focus on managing the high-cost pharmacy at all?
Yeah, thanks, Bob. Great question. So on pharmacy, our guidance to customers is